Hello, everyone, and welcome to today's webinar. Today, you will be hearing from Vatica Health on benefits of payer-sponsored risk adjustment and quality programs. Before I turn it over to the team to get us started, I do just want to go over a few housekeeping items. So you will notice that your cameras and mics will be off for the duration of the webinar. If you do have any questions, please feel free to drop those in the Q&A box down at the bottom of your screen. The team will answer these throughout the duration of the webinar or at the end. And any questions that they're unable to get to, that they will follow up with you directly afterwards. And without further ado, I'm going to turn it over to Whitney to get us started.
Thank you, Bailey and Rise, for hosting the webinar, and thank you and good afternoon to everyone who's joined. My name is Whitney Chernoff, and I'm the Senior Vice President for Vatica's Provider and Payer Client Engagement teams. And today I'm joined by two physicians, Dr. Charles and Dr. Rye, to discuss the benefits of payer-sponsored risk adjustment and quality programs in the current healthcare landscape that requires both better documentation and a higher level of focus on compliance. First up will be Dr. Charles, who is the Chief Medical Officer and Chief Medical Informatics Officer at General Physicians, PC, and Chairman of the Physician Leadership Board for Great Lakes Integrated Network. He is going to talk about his initial reservations about a point-of-care program and how the right solution benefits his practice. Following Dr. Charles will be Dr. Rye, who is the president of Guthrie Lords Medical Group, formerly owned by Ascension and recently acquired by Guthrie. Dr. Rye will talk about his requirements for a payer-sponsored program and what has made it successful for his medical group. Following Dr. Rye, I'll wrap us up with some key takeaways and facilitate Q&A. Dr. Charles, why don't you start us off?
Thank you for inviting me this afternoon. I'm excited to be here today. I am, as you mentioned, the Chief Medical Officer and practicing internist at General Physician. General Physician is, just as a bit of background, one of the largest medical groups serving Western New York and Northern Pennsylvania. We've been in existence since 2010 and are really a broad integrated network that's patient-centered, provider-led, and really this unique blend between primary care physicians and specialists to really clinically integrate us. You can see kind of the size of our practice. Since this slide was made, we're now well over 300 providers, 25 specialties, about 85 practices, and about 55 locations. And I think when you have the size and scope, worrying about proper coding, proper attentive to coding detail, but also how you integrate that in day-to-day practice for primary care physicians is critical. And the Vatica tool at this point is an outstanding tool that they've been very flexible, very willing to work with us in our physician needs, as well as our business needs as we've moved forward. Initially, when we were working with Vatica, the product was very difficult. There was issues with the way that the documentation was. There was just the overall strategy was not at a level that met either the physician or the business needs. Working with Vatica, there's been tremendous change over the last number of years, making this one of the most vital streams of information for our organization, with a progressively increasing uptake for the number of visits that we've been able to accomplish. And we believe the value we drive from both a business and a clinical perspective. And really, what were our reservations around this product? I think one of the really big things is how you integrate it into the clinical workflow. How do you make it valuable for the provider? How do you make it easy for the provider? And so there's really two ways that this is done with the current iteration. One is the pre-visit work, and that is work that's done by Vatica that on each patient that we're going to be seeing, whether it be with an annual wellness or an outside an annual wellness visit, where there's a listing of the high complexity codes that we want to touch on, but also what are the gaps in care? Is the patient up to date with diabetes measures, screening like mammograms and colonoscopies? This has been incredibly useful for our providers. If you think about it, a provider is really struggling to get everything they want to get done. And if there's a checklist, if there's a group of information that we can reference before we see the patient and keep in mind, it really makes the visit more valuable. Also, the high complexity codes really help us focus. Are we focusing on the complication of diabetes? Are they on the right combination of medicines? a great code that's looked at as atherosclerosis of the aorta. Are we properly treating their vascular risk? Because often they might be undertreated. And what should our goals of care be? And really, the right solution to this pre-visit product that Vatica has provided us has been incredibly useful for our providers. And then post-visit work as well, how you streamline that and really work that into the workflow of our day. And then as you look at this, not only is this product valuable for coding and for pre-visit and post-visit work for the provider, but how do you kind of align incentives for the providers as they complete these visits and as they do the work that's required to not only satisfy the business needs, but also the clinical needs. So I think as we look at that, the benefit of a point of care solution such as this Vatica product, which we really enjoy, is it really helps us stratify what is the true level of illness or true illness burden of these patients. While we're doing that, we're addressing these issues and really getting to what are some of the gaps in care so that we can really make sure that these patients are receiving the best care that they can receive in our practices. What we found is that there's been a tremendous improvement in the HEDIS measures. You can see these graphs here, where not only is each year associated with an increased level of annual wellness and physicals, but our control of diabetes, our control of blood pressure, amongst other things, has progressively improved. This not only helps us care better for our patients, but reaches some of these value-based rewards that are so helpful. And really what it did is not only help us align what's going on from a business perspective, but how does that play out clinically? How do you meet the business needs and the clinical needs through the vehicle, which is the provider that's seeing the patient? So I think the work that Vatica has done has been really valuable. And I think what we've looked at General Physician is this financial gain really has a lot of benefits. And overall, patients have remarked that the docs seem on task, that the providers seem really interested in their complex medical issues, and really allows us as providers to focus on those areas that need attention. While we're doing this, not only are we giving the patient better care, but we're capturing more revenue through some of these services with the annual wellness and some of the gaps in care. And what we've decided to do is not only incentivize our colleagues, but also really with this captured revenue, we've helped kind of amplify the effect of this product by building other services. We've built clinical pharmacy and have a very robust clinical pharmacy program, dietary, care management, a home program, a behavioral health program. So we've used the resources that we've been able to garner from this tool to really help our patients, thus amplifying care. Really, the providers are engaged because they know that these resources are being reinvested. And not only are we providing better care, but we're meeting the value-based needs that our organization has and actually improved our performance revenue-wise considerably. It's a very, very exciting time. And I think if I was looking at what a payer can do, what they can do is, I think one of the things that we've done over the last couple of years, and this slide shows that, is not only are we leveraging these visits in an annual well, but also outside the annual wellness. So as early in the year as possible, have somebody look at the chart, what codes may have dropped off last year, what are the gaps in care, and get that in early, submit that high complexity code early, but also address these gaps early. Some of these things may require planning, colonoscopy, mammogram, things like that. And really what that allows you to do is, again, kind of meet that dual pathway of not only what the clinical needs are, but the business needs. And so if you're working from a payer standpoint, how you kind of work to really work as a separate, not a separate entity, but kind of with Vatica, with the payer and the provider to kind of create this collection of tools to really help the provider at point of service. And I think it really does improve the communication between the patient, the provider, and the insurer as to what's going on. But I think really to emphasize the number of visits that we're doing outside of just an annual wellness continues to kind of be a really important piece of this whole puzzle. So that's been very valuable as well. And I think, what we've kind of decided around best practices for patients and best practices to engage our providers is really about how we share all this data with our providers And we really want to do this in a payer agnostic level. So we treat everybody kind of the same way, whether you're one insurance or the other. Again, most of our marketplaces move to Vatica, a lot of it based on our advocacy, because we believe this to be such an excellent product. And I think as we look at this, one of the things that was very important in the post-visit work was, how do we reduce the amount of time that a provider has to do to kind of fill out the forms, the paperwork. I think what really has happened is our doctors and providers have documented better during the course of their visit. So the time really becomes less. And what you do by doing that is reduce the work that's required in the so-called busy work that we hear about, the clicking, and really allow our providers to work at the top of our license. So overall, this product has really grown. Our numbers have increased, and now we're up to over 80%, 85, 90% is our ultimate goal this year of completion of available Vaticas. So with that, I'll hand it back to you, Whitney, and I've enjoyed speaking with you all and look forward to questions about this material.
Thanks so much, Dr. Charles. Dr. Rai, I'll hand it over to you.
Okay, thank you, Whitney. Good afternoon. It certainly is a pleasure and a privilege to speak to all of you. I think a lot of what I will amplify on is things that Dr. Charles have just talked about, but I also want to go a little bit deeper into our journey. So I'm in Binghamton, New York. I'm a practicing internist. I'm the president of our medical group. Our medical group is also multi-specialty. It's not quite as big as Dr. Charles' group. So we're about 280 clinicians. About 60% we are primary care and about 40% specialty care. For the longest time, for most of my career, I've been with Ascension Health. And on February 1st, we transitioned to Guthrie. And the reason why we did that, we wanted more of a regional partnership. But the journey to where we are now was mostly with Ascension. And basically, about, I want to say 3 or 4 years ago, we had our initial foray, and just like Dr. Charles was saying, with our partners with Vatica Health. And at that time, it was just not ready for prime time. There was no way I could take this forward to a group of clinicians and ask them to do one more thing in a very, very busy day. You'd have to come in and out of different systems, and there was just no way that we could, even have a conversation about this. And so, our colleagues at Vatica Health, they took the kind of discussions we had, they tinkered with their product. I think it took them over a year, and then they came back to us, and now the product that they gave us was very, very easy to learn. It basically integrates with my workflow currently, and that was the first thing that I and our CMIO, we had talked to the folks about, is that it's got to be something that we are doing the work, but it's right there in front of us. We do go into the Vatica the chart for them, but I use the same kind of password. I'm into their chart within I don't know, five seconds, and everything I need to answer a clinical question about closing a gap or more specificity on a diagnosis is right there in front of me. I don't have to come out of my Cerner that I'm currently in and go into the wellness chart for Vatica. Everything is right there. And that was the key. It has to be, just like Dr. Charles said, if it's going to take more than 2 minutes, I'm not going to be able to have a clinician do this because of everything else that we ask our clinicians to do. So I also felt that it was very important that we are able to share some of the extra work and burden, not with just a clinician, but with our teams. And the team-based approach, I'm sure all of us now are pretty close to that, but also the incentive, right? So there is work that has to be done, and the clinician is doing the work. Our risk-adjusted teams and partners such as Vatica and other systems are willing to pay us some money for doing this work to get better quality, to close our gaps. Well, I thought that, it's important that we, the system, share some of the money, but also our clinicians who are doing the work also will share. So basically, the amount that is given to us, half goes to our clinician when they finish the chart, and the other half goes to the system. Now, what that does is everybody's got skin in the game. And it took us a while actually to get approval because fair market value comes in. We already have the salaries for our clinicians. And again, these are not, tens of thousands of dollars that we are doling out to our clinicians. It's per chart completed. Not every patient does qualify for the Vatica program. But where it does help us is in our documentation. And so when I have a patient in front of me, I have the chart in front of me. And so I'm looking things up. So let's just take an example of congestive heart failure. There are numerous types of congestive heart failure: systolic, diastolic, combined systolic and diastolic, acute upon chronic. And so the specificity tells the story, as all of you know. It tells the story of our patients. Our patients are getting older and multiple systems are failing. Now we have to document all of this. But the average time that a clinician in our country has with a patient is about 7.2 minutes. By the time that we get in there and all of the screening questions, are you safe at home, the fall risk, everything that is done has to be done. But then I get in there, I talk to my patient. I don't have a lot of time. But yet there are multiple systems, whether it's COPD, atrial fib, hypertension, cancer, it goes on and on. So in order for me to document, I really need to be able to focus on, okay, this is what the patient has coming up. So the fact that, and Dr. Charles talked about this, is the pre-visit email that I get goes right into my inbox for Cerner, and it says, Jane Smith is coming in, and these are the gaps that we really need to pay attention, immunizations, things like that. So I know exactly how I want to focus on that visit because I only have limited time. And so that's very, very helpful. In the beginning, I was printing this out, but then there's just too much paper. So now I just have it right there next to me as I'm seeing the patient. And again, just like Dr. Charles says, I will agree, is that the patient really likes the fact that, wow, I've done some prep. I know what I'm talking about. I know exactly what we want to talk about, because many times what they want to talk about mirrors exactly what I want to talk to them about. And so these care gaps then are closed. Once we're closing care gaps, it's a win-win-win. It's a win for our patients because, okay, let's say I didn't talk to them about colonoscopy last time, but my pre-visit planning checklist said, okay, it's time for their colonoscopy. So we talk about the colonoscopy. I talk them into the colonoscopy. They get the colonoscopy. We find something. Well, if we find it early enough, we can cure it. If we don't find it early enough because we never went looking, because we don't have enough time to address all their concerns, but now we're focused, well, then, of course, we have decreased the healthcare burden to our systems, to our communities. We also have helped our patients and their families to decrease suffering. And so basically then, we were able to get the approval from the lawyers and everybody else to pay our clinicians. Now, then I went to our clinicians and I said to them, I want you to do this. And you can all imagine my response. It was, oh my gosh, okay, so we want them to be more productive. We want them to finish their notes. We want them to go home on time so that, they don't get burnout. And now I want them to do something else on top of everything. And this is where it comes in. It's got to be quick, it's got to be fast, it's got to be focused, and it's got to be to the point. And so basically, that's what this program allows us to do. We launched the program early in 2023, and it took us a while to get payments out because the first time around, we had to figure out how we were going to do this. Our first payments came in probably, I think it was in December of that year. And that's when we started to see momentum. When we were able to send out some checks to our clinicians for charts that were finished. Then obviously they were talking to their colleagues and word got out, hey, did you get a check? I got a check. And you know how that goes. And then all of a sudden, those providers that were not taking part of this, all of a sudden they wanted to know what Vatica was all about. Even though we had talked to them about it, they were a little reluctant. I only had one clinician out of our about 100 primary care, but not everybody has joined yet, who says, what if I don't want to do this? And I think that's a good question. We don't mandate anything here. We explain the why. Once you explain the why, then it's up to the clinician. If they don't want to do it, okay, fine. Maybe I didn't explain it right. Maybe I need to go back and talk to them. But once we started to get the payments out, then of course we built momentum. And the more clinicians that join, the more charts that are closed, the more gaps that are closed, and then the payments not only to the system. So, what does the system do with the payment? Well, of course, we're all resource starved, especially after COVID. Slowly, resources are coming back. So now my system has more money to hire social workers, LPNs, MOAs, RNs, you name it, pharmacists, clinical pharmacists that are embedded in our teams to be able to work part of the team to help us take better care of our patients and our clinicians. So our clinicians also are getting these checks. So what are they doing with the money? Well, some are buying lunch to the staff just as a thank you for building camaraderie. Some are buying small things for the offices. And so basically now it is something where we just have kind of been on a journey. It's taken a little while. Everything takes time. But we're at a place where we are closing these gaps. Our documentation is so much better. And again, I will amplify what Dr. Charles says, is even a patient who is not Vatica is now I'm documenting much better. I don't just say congestive heart failure. I will say congestive heart failure, systolic or diastolic. I don't say chronic kidney disease. I say CKD stage 3A or 3B, because when I'm looking at that patient and examining the patient, all of this information is put right in front of me because I have to look it up and talk to them about their labs and things. So now when I go back for the post-visit wrap-up, once the Vatica team has finished the work and sent it back to me, it's very, very much easier. Everything is there. And if I say CKD stage 3A, they highlight that diagnosis. I just click on it, boom. I finished out my chart and I get on to the to the next chart. We've actually hired social workers to help us with SDOH, social disease determinants. So all of this is just trying to take some of this money and build our teams and provide better care by closing these gaps. And so it's been a good journey. I know that our I just continue to marvel at our team with Vatica because they're there at every step. They provide the education, and sometimes our clinicians may forget and they don't do them, and the charts get locked out. And then, they are reaching back out to them. We may need a little more education, but they're always there, and we get that education. And so I firmly believe is that because this is a win for our patient, this is our win for our hospital, this is our win for our communities, is that we are doing a better job with our patients. And I am currently having conversations with my new employer, the Guthrie Health System, to tell them of the benefits of this program, these risk adjustment programs, and how it's structured, and how very little time it takes for me to close the chart. But I do think that it's helping with the quality of the work that I do, and the documentation is so much better when I look back maybe 3-4 years. So I look forward to continuing this journey with the Guthrie team and our Vatica team. So with that, I think I've hit most of the things that I wanted to talk about, but we'll love to have some questions and comments. Whitney?
Great. Thank you so much, Dr. I. All right, just to wrap us up here and summarize some of the key takeaways. So first up, physician leadership buy-in is a must. And I think as you've heard from both Dr. Charles and Dr. Rai, how they speak about the program and the comments they've made, it is really important that it does start at the top, but at the end of the day, explaining the why, right, as Dr. Rai said, really helps support broad adoption. In addition, simple, intuitive, easy solution, easy to use solution. The other interesting thing here to add on is not every physician wants to do things in the same way, right? Some look to close out their charts immediately. Some do it at the end of the day. Some like to batch them up. So what I see as an important aspect to the solution is option, right? The flexibility to be able to meet each physician in the way that they go about their workflow so that it really makes it easy on an individual basis. Documentation improving. So again, the interesting thing here for me is hearing how not only does documentation improve through the program on the visits that are conducted through the program, but it actually improves beyond that. Both Dr. Charles and Dr. I mentioned that it makes you take what you've learned from those coding exercise, but it does then get applied more broadly. From a provider incentive perspective, it definitely helps. It helps reinforce the buy-in. But on the flip side, it also helps reinforce kind of the broader perspective of what is helping physicians. And that isn't always just the money side, the financial side, but it's also additional staff. And, you know, Dr. I and Dr. Charles both talked about the additional staff and focus areas they were able to put those resources to help the broader community of physicians, which ultimately impacts patient care. And last, but certainly not least, probably the most important item on here is addressing chronic conditions, closing care gaps does make patients healthier and supports the overall healthcare spend. A lot of what Dr. Charles and Dr. I spoke about were to that exact point. And even the comments about the patients in the room noticing that there is a higher degree of preparedness and, you know, commenting on that, I think is pretty amazing. So thank you both, Dr. Charles and Dr. Rai. And there is one question that has come in, and I will go ahead and address that one. And if there's any others, please feel free to put them into the chat. So it's a two-part question. The first is, how does the product work with your EMR platform? So Dr. I think that question actually came in right before you started speaking, and I don't know if you saw the question or not, but you did touch on this a little bit in your discussion, just in terms of you don't have to leave the platform. It's all there. You don't have to go into Cerner, but each group has a different setup. So just kind of more broadly speaking, going back to that optionality comment that I made, there is the ability to integrate directly into the EMR, but there is also the ability to log in a web-based portal. And, you know, not all providers want the exact same thing. So I think having that option is very important. But is there anything else you or Dr. Charles would like to add to that?
No, I think it's basically seamless right now, and that's the key. So all the information I need is right in front of me to answer the question that is being posed.
Yeah, I would say that I find it great that the Vatica team has been willing to work with us to try to begin to integrate, like Cerner is and Epic is, into our small regional Med platform. And I know that there have been discussions. Again, I think the one key phrase to your point, Whitney, is flexibility. This product is incredibly flexible, incredibly valuable, and a real worthwhile investment by both the insurer and the provider, because ultimately the winner is the patient.
Yeah.
And why we do this is to help our patients. And I can tell you that this has been probably the single biggest way that we've been able to build our team, and then that amplifies itself. So again, I'm just thrilled to be part of this conversation and the opportunity to help our patients.
Great. And the second part to that is, do you have incentives for quality gaps to help make those a priority with risk gaps? Specifically for this program, the incentive applies to all, so both addressing risk and quality. There is another question. Currently, we're sending pre-visit messages for unevaluated and suspected HCCs before the patient comes in directly to the provider. Is there any other recommendation to make it more efficient? And are you using an HCC AI tool within the EMR? So I will mention that there are definitely lots of different types of technology, including AI or NLP, and they all bring different value. I think the key thing here is, at the end of the day, it can't be technology only. Otherwise, you're putting the onus on the physician to figure out what's right and what's not. So I think one of the key differentiators for this program is having the Vatica clinical consultants, the VCCs, doing that prep work, including any of that technology up front, but then reviewing and ensuring that the documentation is there so that when it is then provided to the physician, you've had that layer of both technology and service. And I think that's really the key component to why it's been so valuable to help the physicians. And feel free to add anything else that I may have missed there.
I think you hit it right on.
Okay. And we will be sending out an email with access to the recording and slide deck if you joined late and weren't able to catch the beginning. All right, any other questions? If there are no other questions, I will pass it back to Bailey to close us out.
Awesome. Thank you so much, Whitney. And thank you so much to the Vatica Health team for putting on today's webinar. I am going to go ahead and launch a webinar experience survey. So if you could just take a few moments to fill that out, that would be great. Let us know how we're doing.